Molecular targeted therapy has revolutionized the treatment of renal cell carcinoma, RCC, particularly for advanced and metastatic stages. RCC is characterized by specific molecular abnormalities, including dysregulation of angiogenesis and aberrant cell signaling pathways. Targeted therapies exploit these vulnerabilities, offering improved outcomes compared to traditional therapies like chemotherapy or immunotherapy. Key molecular pathways in RCC. 1. Vascular endothelial growth factor VGF pathway. RCC is highly vascular due to overexpression of VEGF, which is stimulated by hypoxia-inducible factor F accumulation. HF accumulation often results from von Hippel-Lindau VHL gene inactivation, a common genetic alteration in clear cell RCC. 2. Mammalian target of rapamycin mTOR pathway. mTOR regulates cell growth, proliferation, and angiogenesis. Dysregulation of the PI3K-ACT mTOR pathway contributes to RCC progression. 3. Other pathways. Aberrant signaling in pathways such as MET and AAXL also promotes tumor growth and resistance to therapy. Classes of molecular targeted therapies. 1. VEGF pathway inhibitors. These drugs inhibit VEGF or its receptors, reducing angiogenesis and tumor growth. Tyrosine kinase inhibitors TKIs, examples sunitinib, pazopanib, axitinib, cabozantinib. Mechanism: block VEGF receptors, VEGF1, 2, GFR3, and other kinases. Clinical use: first-line and subsequent therapies for advanced RCC. Monoclonal antibodies, example bevacizumab. Mechanism: binds VF directly, preventing it from activating VFR, often combined with interferon alpha for synergistic effects. mTOR inhibitors. Targeting mTOR reduces cell proliferation and angiogenesis. Examples everolimus, temzirolimus. Clinical use: primarily for patients who have failed VEGF-targeted therapies or those with poor prognostic features. HL3. Multi-target TKIs. These drugs inhibit multiple pathways, including VEGF, MET-T, and AXL. Examples: cabozantinib, lenvatinib. Clinical use: effective in overcoming resistance to first-line therapies. 4. Combination therapies. Combining targeted therapies with immune checkpoint inhibitors, ICIs, has shown superior outcomes. Examples: axitinib plus pembrolizumab, anti-PD-1, cabozantinib plus nivolumab, anti-PD-1. Benefits: enhanced tumor response, prolonged progression-free survival, PFS, and overall survival, OS. Clinical considerations. 1. Efficacy and resistance. Targeted therapies offer improved PFS and OS compared to traditional therapies. Resistance mechanisms, e.g. VEGF-independent angiogenesis, can limit long-term efficacy. Sequential use or combination strategies are used to overcome resistance. 2. Adverse effects. Common toxicities include hypertension, diarrhea, hand-foot syndrome, and fatigue, VEGF inhibitors, and metabolic abnormalities like hyperglycemia and hyperlipidemia, mTOR inhibitors. Management of side effects is crucial for maintaining quality of life and adherence. 3. Biomarkers. Identifying predictive biomarkers, e.g. VHL mutations, HAF expression, can help optimize therapy selection, but such markers are still under investigation. Future directions. 1. Biomarker development. Efforts to identify biomarkers for patient stratification and resistance prediction are ongoing. 2. Novel targets. Research into new molecular targets, including HIF-2 high inhibitors, is promising. 3. Personalized therapy. Integration of genomic and transcriptomic profiling could tailor therapy based on individual tumor biology. 4. Combination regimens. Trials combining multiple targeted agents, ICIs, or other novel drugs aim to enhance outcomes. In conclusion, molecular targeted therapies have transformed RCC management, providing more effective and tailored treatment options. Ongoing research seeks to refine these strategies further, improving survival and quality of life for RCC patients.